Welcome to Connections, the podcast from addiction professionals of North Carolina, where we explore the nuances of addiction and mental health through the lens of policy and practice.
We're your hosts, Morgan Coiner
and Sara Howe,
and we're here to help you see how it all connects.
Today, we're very excited to have a fellow podcast host, David Smith, host of The Cost of Care. David, you've been doing this podcast for over 2 years now. We're super excited to have you to talk to us today about how this podcast came about, the connection it has to behavioral health, and the work that you're doing to improve healthcare across this country. So welcome.
Thank you. It's great to be here.
We're thrilled to have you. Tell us how this podcast came about and the work that you're doing.
It's an interesting story. So there's a company called Limonada Media who has two co-founders, Stephanie Whittleswax and Jessica Cordova Kramer. And the thing that's interesting about these two women is they both experienced a really similar loss in that they both had a family member who had passed away from an opioid use disorder. And so as part of, they kind of found each other. Stephanie had written a book, and that book had gone on to some acclaim about her experience. But as they kind of found each other through that shared experience, they wanted to launch a network to tell stories and really to try to tell really personal stories that could cut through ideology, could cut through all the different economic arguments we create against funding certain things or making certain policy changes. And try to get at the heart of these issues. And so they launched a show called Last Day, which is still a show that they have running today. It's a beautiful show. Season 1 was focused on opioids. And I had a chance to kind of meet them by being a guest on their show. And in the course of getting to know them a little bit better, we said, well, God, I mean, like opioids, it's a big subject, but it's kind of scratching the surface. We have this $4 trillion albatross of an industrial medical complex in this country that where we spend 2 times more than every other developed nation on a per capita basis for health and health-related services, and we get really crappy outcomes, lower life expectancy than everybody else. So can we take that same formula and create a show around it? Can we tell really personal stories about how people interact with their doctors and insurance companies and the like, and then leverage experts to dig into, well, what is the anatomy of why that happened? And then ultimately, if you're a friend or family member, somebody going through this, how can you engage differently? Alternatively, if you're just a really active person, how can you vote differently, lean into the policy conversation, and so on? And so we launched the show. And the last thing I'll kind of just say as a bow to this is we launched it a little bit on the basis of my own story with addiction in my family growing up, where I feel like the system really failed my father, my brother, and my sister who passed away from OUD-related challenges. And so we kind of use that as the anchor. And then over the course of time, we've had the privilege of talking to some incredible people who have gone through harrowing things and been inspired by their courage and their resilience. And it's been really instructive on a bunch of different ways we can make the system suck less, as Limonada would say.
And so I think that's really instructional, as you say. How can we fix the system? What can we do differently? And I know you come to this from not a practitioner or clinical place. I mean, you come to this from an economics point of view. And I find that fascinating. One, it takes all of us to fix this problem from every facet. But you're able to really look at it from a macro lens of what are we seeing? Like you said, $4 trillion in this company. I think I've heard you in this country, and I think I've heard you say this before, we are the sickest country for $4 trillion. I mean, the amount of money we put in this. So as you've interviewed people across the spectrum, whether it's in this behavioral health addiction space or outside of it, what have you found that really you think we need to be focusing in on in healthcare? What are some of the takeaways that you've learned as you've done?
Yeah, so many things. I think in some ways the experience has really helped to validate a bunch of professional points of view I kind of had as I walked into the experience, but it's given it some color and some depth. And in other ways, it's illuminated new areas for me. But I think my core ethos on this just continues to remain. We are a country who operates our healthcare system on annual underwriting cycles. Once a year, we underwrite insurance for people. Those people switch coverage, they switch employers, they might age into Medicare, they might no longer be eligible for Medicaid. So if you think about the constitution of this, we have all of these different downstream ways we pay for healthcare in this country, government sponsored, employer sponsored, and so on. And then all these different markets in which that happens, and then all these different products and features under which that occurs. And so if you actually step back and start doing the math on that, we have like 500,000 permutations of a broken healthcare system across the United States. So the base economics of the system, as it pertains to financial incentives and the like, none of that really works the way it should. We don't pay for value. We just pay for people to do things. And then we've messed that up 500,000 times through all of the complexity. And every time we try to make the system better, for example, the Affordable Care Act, wonderful legislation, broad access to a lot of people. I'm full supporter of the Affordable Care Act. But because of our intransigence to consolidate some of these programs, we just added another layer of complication to a $4 trillion system. So you have to kind of ask the question, does it make it better? Does it make it worse? But throughout all of those things, the system is fundamentally wired to only think about people over 1 year time horizons. We don't think about them over the long run. We pay for things when people get sick, and we try to not pay for them to the degree we can. And we don't make the investments, quote unquote, upstream and the kinds of things that can really affect a person's lives. And as you know, in the work you do at AP&C, so much of what manifests in our lives physically starts with what happens between our ears. And what happens and develops between our ears is a function of our genetics. It's a function of how we grew up. It's a function of the people who are around, our education, all these things that most of us don't really have the ability to control. And as a society, we don't recognize the uniqueness of that. And hence, we don't invest in mental health. And because we don't invest in mental health, we end up with this world where people have rampant CKD and cardiovascular disease and type 2 diabetes and hypertension. And we find ourselves just stuck. And so to me, the experience of the show in conjunction with the work I get to do every day just continues to reinforce that, this is a self-inflicted problem. We know enough to solve our way out of this. It's investing upstream. It's changing the economics of the system. And it's moving a bunch of cheese from a bunch of people who get rich off of the dysfunction of this $4 trillion system.
Yeah, absolutely. And as you've dug into all these different pieces, like you were just saying, all these different pieces of the healthcare system, how often would you say addiction and mental health has intersected when you wind up having these conversations?
100% of the time.
Wow.
I'd bifurcate it and say there are two roots of that. One is that there's a mental health disorder or an issue with substances that was catalytic to some medical event or situation that somebody had to navigate. But the other is as people navigate the system with a friend, a family member, a child, a parent, the stress of navigating this system is so immense. And so in every single conversation I've had for 2 years, every single one, somebody has talked about the mental health effects of having to interact with our system, and that it's created anxiety, it's created depression, or it's taken some other underlying mental health disorder like BPD and it's exacerbated it in some way. And that's a very real thing because, if we don't have great access and resources for physical health, we sure as hell don't have it for mental health. So we're creating this duality of challenges that just feed off of each other. And you do that enough times on an intergenerational basis, you get a society with a bunch of broken people. And we are a society with a bunch of broken people, myself included. And that takes a lot of thoughtfulness and deliberation to move through and to improve.
I think you bring up a good point too, like talking about navigating the system. It's an issue separate sort of from the finances of it. I remember when my dad got sick, there were two reasons we were able to really get him the care he needed. One was that he was at the hospital where my brother-in-law was a physician. And two, he worked in health insurance his entire life. So when something happened, on the insurance end, we called the president of the insurance company and we're able to say, we don't understand what just happened. And he was able to get us in touch with the right people, right? But like, those are two very privileged, things to be able to do. Like, I can't call the president of health. Like, yeah,
healthcare shouldn't be
no
privileged.
one can do that, and you shouldn't have to call the president of the company to get decent care. Like, and it's just I don't know. I can like get on a real soapbox about it, but it's that navigation piece too that I think, organizations in the mental health field are really trying to address on the ground, because what we do know too is you can't learn how to navigate a system in a moment of crisis. And if the system is not intuitive, which it's not, it means people aren't getting help. So like, it's layered, the issue that we're talking about,
Yeah, Morgan, you're 100% right. And it's, if you're navigating a chronic disease diagnosis, cancer or type 2 diabetes or something, like overnight, you have to become an economist. You have to become an expert in revenue cycle and how you argue against a denied prior authorization or a claims denial. And like literally, to this day, and I mean, we're not big utilizers of the system, but I literally have a stack of mail in my office that I take from every provider I get, and I just let it build up for 2 or 3 months. And then on a Saturday, somewhere along the way, I will bring it all out and I will start to match up what came from who against what policy. And it will take me a full day to unpack. But if I was trying to do that like day by day, like that'd be a part-time job. This is not easy stuff for people. And so what's so maddening about it is we have an incredible system. We have amazing clinicians. We have amazing technology, amazing science. Like we know how to heal people. We know how to heal people in the 21st century of a lot of things. And all the administrative bullshit we put around it prevents people either from getting that healing or it exacerbates those events in the first place, let alone just even investing upstream to prevent the onset of the stuff in the first place.
As you talk about that, and I've had the opportunity to listen to the show several times, I think you really do a good job of pointing this out. Like what we're doing is exacerbating illness when we have the opportunity to create wellness. What's been the reaction that you've had? What kind of reactions have you seen to the show?
It's generally very positive. The reactions, as you might imagine, come down to this age-old, 70-year-old, I guess, American debate about is healthcare a right, or is it a privilege? And who should be the ultimate administrator of those resources in this country? Is that a job for the government, or is that a job for consumers who are in the free market, laissez-faire kinds of concepts? One of the things that it continues to be vexing is I will hear comments or see comments from people like, well, I'll tell you why we're all sick, why we have such a prevalence of type 2 diabetes and obesity. It's because we're all fat and we're all lazy and we don't, we need to work out more and make better food. Oh, no shit. Like, thank you, Dr. Genius. We really appreciate you understanding the anatomy of that. But what people don't really dig into is all the different typologies of a person's genetics, lived experiences, all the things that really are more causally related to or correlated to what drives these things in the first place. And we all, this is such classic American culture. Like, we evaluate other people and what's happening without any information at all, and always through the lens of our worldview. Well, I exercised, 30 minutes a day for a year and I lost weight. So why can't that work for you? Well, because people's bodies are different. And it is this inability for us to really think in a compassionate way about the plight of others and extend grace that allows us to understand that different people make different choices for different reasons based on a bunch of different factors we know nothing about. And so it's frustrating when people do that because it's short-sighted and it's not productive. Like, we can argue about the semantics of personal responsibility all day long, but at the end of the day, our economy is only as good as what it produces. It will only produce at the sum of what our contributions are. And don't we all want to live in a country where we are all optimizing our contributions because we are all well? Like, we should all want that.
Yep. So I'm gonna
make it sound so simple.
I know he does.
I'm like,
Listen to the show.
yeah, we fixed it. Let's go.
I'm gonna take you.
Well, but see, and Morgan, that's the frustrating thing too, right? Is because like this is not complicated, but we make it so complicated through ideology and through people that make a lot of money off of the dysfunction.
Well,
yeah.
That's a whole other show.
Yeah,
about making the money off the dysfunction. But I think that's another show.
Yeah, right.
That show is called Disconnections, not Connections.
That's right.
True, yeah.
Or I think it might be called American Greed, maybe. Yeah. Who knows?
But you know what? Here we are, just creating more podcasts.
More podcasts, yes. Well, one of the things, since we have you, and you are a healthcare economist by training, I just want to get your thoughts on something really exciting that North Carolina has recently done, the 40th state in the union to pass Medicaid expansion, which has not yet officially gone live, but the bill has been signed, sealed, and delivered. And any day now, we will see the actual live rollout of Medicaid expansion. And with that, since we are state number 40, there's 39 others that have done this, and you have done a lot of work in multiple states around healthcare economics. What can North Carolina expect now that we've got Medicaid expansion coming?
Oh, it's a great question. I think the first thing to expect is you're going to have a lot of people with a lot of needs that have not had those needs met that suddenly do have a pathway to meeting those, and so there's going to be a jump in utilization. I think across the states, and that's emblematic of what we've seen in other markets. It manifests differently, and it manifests over time in different ways, but it always manifests. I think the second thing, regrettably, to expect is you're going to have a litany of providers that have to make some difficult decisions about how they interact with the program, and patients that have Medicaid. And the unfortunate thing is we underfund Medicaid as a country. We underfund it in every state we offer it in. And because of that underfunding, it can become financially burdensome for a lot of providers. Now, I have my own thoughts on why that shouldn't always be the case, but it puts a lot of providers in a position of having to throttle the number of patients they'll see in a particular way. So even though we think about Medicaid as like, hey, now suddenly everybody's covered, well, coverage is different from being able to access systems. And when we talk about high-cost nephrologists, endocrinologists, mental health professionals, the economics of their craft are oftentimes inconsistent with the rates you see in Medicaid. I think the third and final thing you'll see is, and I hope you'll see, is, okay, now that we are funding and reimbursing for Medicaid, how do we make that program more efficient? How do we hold managed care organizations and then ultimately providers to account for their performance? What are the different things other states have done that have worked, and what has not worked, and what can work uniquely well in North Carolina? And that's, I think, for anybody listening to this that works in the industry in the state, I'd really focus on that. Medicaid coverage expansion, that's Ticket to Ride, and it's a great ticket, and kudos to North Carolina for passing it. The real work becomes now, how do you take the constrained economics and create a program that really does improve people's lives? Because that was the vision of the program. It's the vision of the program today, and it needs to be the future of the program if we're going to get out of it what we need to.
So what would you say then to the policymakers that might be listening as you talk about the other states and some of the financing mechanisms that we can look to? I mean, the beauty of this is we're not the first ones out of the gate. So there are some lessons learned and maybe some missteps we can learn from. What would you suggest to policymakers who might be listening on how we could get it right?
Yeah. couple of things come to mind. One is the model of paying a managed care organization a fixed rate for them to turn around and pay providers a fixed rate on a fee-for-service basis is unsustainable in Medicaid, and it's just dumb. Like, just I'm sorry to use such crass language, but and Medicaid is all about efficiency. It's how do we gather as much information and create the right clinical resources at the right place at the right time for patients over an extended period of time. And the only way you're going to do that is if you are incentivizing the system to organize itself differently. So the way you wield that dollar at the state level and the way it gets all the way downstream to a paraprofessional, a mid-level practitioner, or a doc matters a lot. So those payment mechanisms, I think, are critical. I think the second thing to really understand is that people on Medicaid often there's a higher prevalence of acute conditions, chronic disease, and the like. And again, if we think about the causal factors of that, it's social factors, it's mental health factors and drivers. If you want to create sustainable spend in the state, yeah, you got to meet the needs people have that day. But you've got to be thinking in terms of a 5, 10, 20, 30-year budget horizon. Most states do their budgeting in 10-year underwriting cycles or forecasting cycles. We have to think about this stuff, I think, much more over the long term. Last thing I'll just say, Sarah, is that the use of technology as a means of sharing information between hospitals and community-based organizations, or providing services to people that maybe don't need to go to an emergency department, but could access technology services in a way that can redirect them. There is a lot we have access to now, and it would be to a state's detriment to not really put the full weight of its purchasing power behind technology to help make the program more efficient. There's a lot. I get in arguments in Chicago and in Illinois with people all the time. Like, yeah, Medicaid is underfunded, sure, but we suck at being efficient with the dollar we do have. Let's get really efficient with that dollar in terms of how we organize incentive structures, use technology, link different parts of the system together. And maybe we'll still be underfunded, but we'll be getting a heck of a lot more out of our money than we are today, just running a fee-for-service game.
We know is on the horizon that the work you are leading in this country is transparency and coverage. And how that intersects with addiction and mental health services, which I'm going to go on a limb here and say a lot of our listeners are probably like the transparency and what are we, what is that? So if you can, and I always hate to be like, if you could boil that to like 5 minutes, right? Yeah. Some really big concept, but if you could give us just a snippet of what that means, why it's important and why it's going to be critical for our particular work in addiction and mental health.
And if you have kind of the question, how much does care cost in the community? How does that the cost of care kind of line up with other members of the community or other parts of the country? You've not been able to really answer that question historically. You can kind of take a good guess at it. You can use claims data. You can use some cost accounting data. But when we talk about a free market, right, which is kind of this argument that if we let the market be free, then, efficiency increases, costs drop. Well, markets require something called information symmetry. It means the buyer and the seller kind of have a similar idea about the value of what is being transacted, what I am buying versus what's being sold. Electronics works that way. Automobiles work that way. Like every other part of the country or economy that's not that is not super regulated functions that way because we have that exchange of information. We don't have that in healthcare. We have no idea in healthcare what something actually costs until David sits down 3 months later with a stack of mail and says, here's what it cost me, here's what it cost the insurance company, because we go through all these different permutations of it. And then to go back to what I said earlier, when you have Medicaid, Medicare, VA, employer-sponsored insurance, exchanges, you have all these different mechanisms, all these different contracts, across lines of business. What does something actually cost? It's impossible to know. So however somebody might feel about the Trump administration, one really positive thing they did in Health and Human Services and the Centers for Medicare and Medicaid Services was that they introduced some transparency regulations. And what it requires is that if you are a commercial insurance company, you have to post all of the rates you've contracted for with every single provider across the country. So for every network type or every product against everybody you've contracted with, for those discrete contract arrangements, you got to post a file. And the file's got to have all the rates for all the network services. If you do the math on that, it gets crazy. It's trillions of lines of data that drop into the market every 30 days. But it's super cool because now we actually know what's in these contracts. We have information symmetry. So now if I can take those rates and then I can take what I know from claims and utilization, and I can even take what's happening at the facility level and cost accounting data, not only do I have a sense of the economic value of how this stuff's being transacted and with whom, but suddenly I have this fuller view of how healthcare is working in this country, and it's going to help moderate the prices for these things, I think, over the course of time. So this transparency stuff, I think it's in its infancy. I think over the next 3 to 5 years, you're going to start seeing a much better way for us to understand what different things cost in different markets. The real value of this is that like in every healthcare conference I've ever gone to, somebody will invariably have a slide that says value equals cost over quality. You're like, great, I can kind of get to quality, but what is cost? Because there's a bunch of different ways to infer that. Well, now if I know cost and I know quality, I know value. And if I know value and I can measure that in a ubiquitous way, and I'm a consumer trying to understand how to navigate a system, devoid of information, that value delimiter starts to become a lot different in how I think about myself as a seller of services, a buyer of services, or a utilizer of the services. So I don't know. I've been hyperbolic and excited about things in the past. I think this is going to change the face of our industry over the next 5 to 10 years, and I can't wait for it. It has been so fun to watch. We'll help an addiction treatment center, our mental health provider, and we'll show them their rates, and we'll show them where they're getting screwed by a payer, and they'll go call the payer on their stuff, and suddenly they get a 7% bump in their rates, and they're at quote unquote parity with how others are getting paid. And it's amazing to watch these payers who have obfuscated for years and decades finally be held to account for the contracting practices that leave so many really important organizations bereft of the resources they need to do their critical work.
I want to say just thank you for making these very complex topics so much easier to understand. Like, I was not a policy person. Like, this has been new to me since coming to AP&C, and I'm just really thankful to have people who can make this not sound as hard as it sounds. So I just want to say thank you, because I feel like our listeners will appreciate that too, because a lot of this stuff sounds scary and difficult and big and hard to understand. So I'm just really grateful we have you here to help walk us through it.
Yep. And we hope you'll come back, of course, as you dig into this data and what we see more in terms of addiction. And then as you grow your podcast, and what you hear and where, of course, we can connect. That's the important piece. So we're just grateful to have you, and grateful to have you in the fight for everything.
Oh, thank you. Thanks for the invitation. Thanks to you, your staff, and your members, above all, for the really important work they do in North Carolina.
Yep, for sure.